We'll let the music bed come in, and right after he gets through talking, and then you come right in after him.
Okay.
You got this. You got this. I'm proud of you. You're doing great.
Okay.
Yeah. I like that one. Mm-hmm. Here we go. Let your music play a little bit.
All right. Welcome back. This is Footsteps for Life. This is a call-in radio show. You can call in at 937-457-1210. We are now streaming live on Facebook Live. I think it's Tanisha Richmond on Facebook. I'm streaming live. And this will also post later on Spotify, which is my podcast. So this afternoon, we've been talking about vascular disease, smoking, dialysis. We talked a little bit about marijuana. And, I wanted to give a plug about another thing that I'm doing in my practice as well, trying to survive through this pandemic. I have started making custom face masks. I wanted to show a couple of them. Since we're going into the election, I wanted to show this one, Vote Like Your Ancestors Died for It, because a lot of our ancestors died, were hosed down, hung, killed. Vote. We have another different vote style. And then, of course, I have one for Kamala Harris in pink and green for hopefully our first black and Indian first black vice president. And then also I have many of the football teams. This is one of them that I had, Tennessee Titans, but I have most of the football teams as well. And also children's masks, the cartoon masks, face shields, hand sanitizer, t-shirts. I'm actually wearing Won't He Do It in Bedazzled. I don't know if you can see it, but I also can do t-shirts in my office as well. So I'm just out here trying to survive. So the face masks are $10 a piece. The NFL masks are $15, and then the Bedazzled t-shirts are $20. And those can be made in different sizes and colors. And you can always come down to the office. We're at 1323 West 3rd Street. We're open Monday through Friday, 9 to 5. We do close at lunch from 12 to 1. So when we were going to the break, we came up with another discussion. I also have today with me Dr. Julie Gilkison. She is a vascular surgeon with Kettering Health Network. And we were just about to start talking about what is COVID-19 doing to the vascular system. So I'm going to let her answer that question.
Well, as I know that everyone understands this, COVID-19 is a new thing. We have not seen it in the medical community before January, or really December, but in the United States and before January. So one of the things about COVID-19 that we've learned over this last 8 months is that it clearly triggers the inflammatory system. The inflammatory system is directly related to how we clot and unclot. Our blood it needs to be liquid form inside of our blood vessels. So that each blood vessel, if you think about a blood vessel as a tube of cells, think of it almost like the Romans had aqueducts and they had bricks all connected together with mortar. So carried water, it's still watertight, but it's made up of individual cells. So what we've learned is that these cells that are lining the arteries are inflamed and becoming inflamed, and this triggers the clotting cascade, which is called coagulation. So what we're learning is that patients that are getting a higher inflammatory markers within COVID, they are having a higher amount of coagulation, which is called a hypercoagulable state, meaning hyper meaning high, coagulable meaning clotting. So we're finding patients that are having, people that have high inflammation with COVID are having more strokes, which can be a clotting problem up to the brain, more limb loss, which can be a clotting problem towards the legs and the feet, And we're finding that if patients that have high inflammatory markers that are sick in the hospital, we're actually putting them on anti-clotting medications, which can include Lovenox, which can include heparin, and sometimes we're actually adding other medications that can allow the blood to be thinner. Does that mean that everybody needs to be on a blood thinner? No, it does not. It just means that if your inflammatory markers are high in the hospital, that we will look towards working on thinning the blood some. But we measure this, and we can measure this and how it goes. There has been some talk about COVID toe.
Yes, I've heard about that.
I have seen 2 patients in Dayton that actually presented with this. It shows up, for example, if this was a toe, this is obviously my hand, but if this was a toe, it shows up as small little black spots on one or other toes. And we think that this is having a high inflammatory response, triggering these capillaries to clot off. And both patients have described this as painful. Both patients have described this as causing the pain to be just localized at the toe itself, with small little black dots along the toe. Both of those patients I did then sent to the hospital to get tested. They both had high inflammatory markers, and both were placed on anticoagulation.
And they both were positive for
they
COVID?
They were. Now, one of them also had respiratory symptoms, so he needed to be in the hospital regardless of whatever was happening to his toe. And the other lady, she actually presented to the emergency department for the toe. We put her on blood thinner, and she actually went home. But they were both then home quarantined for 14 days to make sure that they were separate.
Oh, now I know we've had some articles come through some of our podiatry magazines where they talked about it, but I haven't seen it. And actually, the pictures that we saw, it was kind of more like the toes were swollen, but you said the pinpoint.
I'm just telling you what I've seen.
Yeah, I'm glad to know what to look for, because it kind of almost describes like what we see with a wart. Mm-hmm. We see the little dots of blood in the toe. Mm-hmm. So for a patient, say someone that has a history of a DVT or blood clots, should they be talking to their vascular doctor or making sure they're on blood thinners or?
Well, if you have a DVT history, this is a conversation you should have with your primary care doctor about what your anticoagulation plan is. DVTs come in 2 forms. They're called provoked or unprovoked. Provoked, it kind of makes sense. You break your leg, you put your leg in a cast for a very long time. Those veins are being stuck in a mold for a very long time. Those veins have provoked in DVT. Unprovoked, that's the more serious one in the sense that you don't know why that's happening. So those are the ones that often you get genetic testing. Sometimes you have cancer workup. Sometimes you have COVID testing nowadays, looking for something to provoke it. It's the unprovoked that are much more complicated and much harder to understand why they're happening. So if you have a history of DVTs, you need to understand whether or not you have a provoked DVT or an unprovoked DVT. If you had, I sat in an airplane for, 20 hours, well, clearly that's a provoked DVT.
Okay.
Whereas if you have a DVT just out of the blue, those are the ones that you have to really talk to your primary care doctor about getting all kinds of workup in the sense of looking for anything from cancer to genetics.
Okay. And you had mentioned about veins,
yes.
varicose veins.
Yes.
Well, you didn't say varicose veins, but how does that relate to vascular disease? Because I have a lot of patients, or just plain swelling. Like I have a lot of patients who are just swollen. And generally I always say, well, how is your kidney, liver, or heart? And then they'll say, well, I'm in heart failure. Well, it's your heart. And then I'm in liver failure. Well, it's your liver. I'm in kidney failure. It's your kidneys. But
swelling is systemic until proven otherwise.
Okay.
So it's rare for varicose veins to be the cause of all your swelling. So I always make sure your heart's okay. Just like you said, make sure your kidney's okay. Make sure your liver's okay. Because those are the things, the chronic illnesses that are really important to catch early. And this may be the hallmark sign. Women have silent heart attacks. It may be leg swelling as the only thing that will tell you that you had a silent heart attack. And that's for me, as a female, that it says, okay, so I need to listen to my body. I need to listen to what my body is telling me. And if leg swelling is the first thing that tells you you have some renal failure, this is a thing you need to not ignore. Don't ignore swelling. Talk to your primary care doctor and say, doctor, this is not what I've had before. Clearly something is going wrong. I need to have my kidneys tested, and my liver tested, my heart tested.
So what about compression stockings? Because I know they are, I need some compression stockings. And I'm like, but we got to check your vascular status first.
Yeah.
I need to make sure we don't cut off the little blood flow you got by putting you in a compression stocking. So when should a person wear compression stockings?
Well, I hate to tell everybody out there, but varicose veins are genetic. Well, not totally genetic, but mostly genetic. So if your mom or dad or aunt and Uncle Bob has varicose veins, well, guess what? It's just as good as brown hair. You're probably going to have varicose veins too. It's not sex, male or female, doesn't matter. It's that if you have a job that stands a lot, a job, where you're standing on concrete especially, these people have higher pressure on the varicose veins because you're standing up on a column of water. All your blood is pushing down against these veins, and the valves inside of the veins, they end up breaking. And they can break in two ways. The vein could get too big, or the valve itself could break. So what is compression doing? Light compression is probably okay for the general population. That's okay. But what we're talking about is medical compression. That's anything above 20 millimeters of mercury, which is pretty tight. If you're not doing what we call compression stocking yoga in the morning, you're probably not tight enough. So I wear compression all the time. My dad has varicose veins. Okay. So I wear compression when I'm in surgery because I'm standing on hard concrete. So what I do is if it's not a struggle to put on, that sock is not tight enough. And for right now, the key is, anything for me, I wear 15 to 18 millimeters of mercury. You can get this over the counter. And even if you have arterial disease, it's probably okay for that lower level of compression. Now, if you start crossing up to 20 to 30 millimeters of mercury, that's the higher medical compression. You probably need to get your arteries checked out, your veins checked out, because that is actually really tight. And those are hard to get on, and I tell people all the time, unless you don't need the medical compression, 15 to 18 is just fine.
So if they're having mild swelling, 15 to 18, you said 15 to 20. So basically the over-the-counter ones.
Yep.
But the ones that I write, the 20 to 30, they need to have some vascular studies first, and then see you. And because I know they'll come in and then this is my favorite topic, lymphedema. Explain what is lymphedema.
Well, let's just start off by lots of lymphedema is just fat. I'm sorry about that. I would love to say that lymphedema is often fixable. It's not.
Okay.
Exercise, we know, does help. Moving your muscles does help. Moving your large muscles, like your gluteal, your thighs, your hamstrings, your quads, does help. We know that muscle movement around the fat that has that extra fluid in it helps. Compression, it doesn't always help. The problem with lymphedema is often it's variable in the sense that you're having a bad day, your leg's really large, and then you have a good day, your leg's really small. So a compression stocking can actually be like a tourniquet if you're having a particularly bad day. So lymphedema is a hard one because it makes it so that there's different amounts of fluid in and among the fat on your legs, and that makes it so that there's different amount of fluid in your legs in general. Losing weight absolutely does help. Compression does help, but I do more of the wraps.
You less. like the Jones compression wraps?
Yeah, or the Circades or the stuff like that. Yeah.
What about the lymphedema pumps?
They do work. They're pricey. They do work. I make sure that everything's been ruled out. Make sure all of the systemic problems are ruled out.
Before they get the pump.
Yeah, but they do work. 90 minutes, twice a day. Sitting in a chair with your legs elevated, the pumps do work. And actually, there's some benefit to the arteries also with those pumps. The problem is they're quite pricey, and not every insurance covers them.
Okay, looks like we have a caller on the line. Good afternoon. Good afternoon. Are you there? Oh, sorry, they hung up. Okay. So let's see, we talked about lymphedema, varicose veins. Oh, so what are the symptoms of vascular disease? So if someone's on sitting at home looking at their feet, what should they be worried about?
Sure.
Or if they see it or feel it?
So I like to distinguish leg pain in kind of two broad categories. Kind of night cramps and day cramps. I know that sounds really simplified, but it helps kind of distinguish what's happening. So at nighttime, if you're having leg pain, often that's a dehydration. Often it's a mineral disturbance like low calcium, low sodium, low potassium, low magnesium. So it's often dietary. Night cramps can lead also to iron deficiency. If you have restless leg, it's often linked to iron deficiency. So nutritional deficiencies lead to night cramps. Unfortunately, also diabetes can be a sign. Night cramps can be a sign of night cramps, meaning like numbness and tingling and burning sensation. That can be a sign of neuropathy. So that night pain is a separate pain. Day pain, so that's more of, I think of it in two different ways. Is it happening while you're moving, or is the pain happening while you're staying still? If the pain is happening while you're staying still, I often think of that as electrical. So we think about spine problems, we think about nerve problems. If it's while you're moving, then we think about plumbing. I'm more of a plumber. So you think about supply and demand. So if I walk 20 paces, and my calf hurts after 20 paces, that means I've outstripped the oxygen delivered to my legs. So it's a supply and demand issue. So that's called claudication. Claudication means a consistent amount of pain with a consistent amount of motion. So pain in your legs that is always triggered by walking 100 yards, that could be a sign that your arteries are blocked. And it's a supply of oxygen to demand of oxygen imbalance.
So restless leg, you mentioned that. And patients always like, I think I got restless leg. What is restless leg syndrome?
Restless leg is where you have an uncontrollable urge to move your legs while you're laying still.
Okay.
And there is some evidence that it could be a sign of iron deficiency anemia. So you do need to have your blood tested if you're having restless leg. There are some nerve medications that do treat it, but those medications do have some side effects, so you need to talk to your doctor about them. Don't just take your aunt's medication. You gotta go get checked out for yourself. You need to have the blood work because it could just be a sign that you're having.
So it's no vascular component to restless leg. It's more neurological.
It is.
Nerves.
The medications that they use to treat that are some drugs that they were investigating for seizure at one point. They're not seizure medications, but that's
like gabapentin, more drugs like that. Yeah. Okay, so because lots of time patients will come to me and say, I have restless leg.
Yeah.
Now, is that a component maybe of like a bulging disc in their lower back?
It can be.
Arthritis or something like that.
We call that kind of the faux restless leg, where it's being caused by nighttime position. So true restless leg is an uncontrollable urge no matter how you're positioned. So left side, right side, forward. If you find that I go to one side and I always have restless leg in that one position, then it may be a spine issue.
Okay.
Yeah.
Well, it looks like I had a caller that wants you to talk about heel spurs, which is right up my alley.
Yeah.
So heel spurs, that is inflammation of the heel. So the technical term for that is called plantar fasciitis. So you have a plantar fascia that attaches at the bottom of your heel and the base of your toes. Over time, that tissue gets tired, it gets tight, and it pulls actually on the heel bone itself. And lots of times people will say, I have a heel spur. So basically what the heel spur is, that tissue is pulled off the heel bone and the body has made a little spur where the irritation is. So the mainstay of treatment for plantar fasciitis is stretching at home. There's a lot of different stretching you can find online. Taking a water bottle, freezing it, rolling it over your heel to see if that calms the inflammation. But generally when you come to see me in my office, the first thing is we get a good thorough history, because sometimes, like I was just talking to Dr. Gilkison, it could be a back injury. So they could have a bulging disc, a compression of a bulging disc, arthritis in their lower back that presents as heel pain in the foot. And then also we're going to get x-rays. So when I look at an x-ray, I want to make sure I see an heel spur, or I'm checking for a fracture, I'm checking for possible cancer of the foot or heel bone. and I'm just making sure the bones are normal in the foot. So the first thing we usually start off with is something called orthotics. So those are inserts. Actually, let me pull my foot up here.
Yeah,
I have them in my shoes. You like my shoes? I like my shoes.
I do.
So this is what is an orthotic. And I have what's called a Fred Flintstone foot. I have a wide, flat foot, which is very common in African Americans. I may see 2% of the population of African Americans who actually have an arch. But this supports what's of my little arch that I do have, and as you can see, it cups the arch and it supports the soft tissue of the foot. So I did get plantar fasciitis a couple years ago, and ever since then, I always wear my orthotics and my plantar fasciitis stays away. So for patients who can't get relief from orthotics, there's things like the infamous heel spur injection. That's where we inject the foot, and I inject right where the patient says the pain is with some lidocaine and steroid, and that gives you immediate pain relief, and then steroid calms down the inflammation in the area. We do have a new form of pain treatment in the office. It is a neurostimulation device that we use. It's similar to a TENS unit, but it doesn't involve any kind of drugs or injections, and we actually can do that in the office. And that's usually about a 15 to 20 minute treatment in the office, and it's covered by most insurances, and some insurances not covered by. It's usually about $40 a treatment, but that's another way to treat heel pain and as well as tendonitis and nerve pain as well. But the mainstay of getting rid of the heel pain is getting into a good pair of inserts.
Now, Doc, you have a fabulous foot boutique. So you want to tell us how we can get those inserts and everything else that you have there?
Okay, so I do have a fabulous foot boutique, and now I have the mask factory I just added. So now we have the custom face masks, we have the t-shirts, the bedazzled t-shirts, I got some cowboy t-shirts, and then we also have now inserts. Well, we sell inserts in the office over the counter that are $30 a pair. We do have some sandals that are $30 that have orthotics built into them, so you can putt around the house or walk around and have some support in your shoes. We sell diabetic socks. We sell hammer toe pads, corn pads, antifungal toenail polish. We have paparazzi jewelry in there. we have compression socks as well as diabetic socks. Some treatments if you want to do your at-home foot treatments. And then also we do have a diabetic-friendly foot spa in the office as well. And that's $20. And that's done in a private room with a massage chair, lights. You get to put on your favorite Pandora channel as long as it's not cussing a lot. Then you have to wear your own headphones. And it's done by the medical assistants. And generally, most patients will do that on the day of their appointment. They'll come in 30 minutes early and then get the full treatment. Then I'll come in and cut their nails or calluses or do a regular exam because those do function as treatment rooms. And then, of course, like me and Dr. Gilkison had discussed, I do vascular studies in the office, which is a non-invasive way to check blood flow. It's just a blood pressure cuff on your arms and legs. And like we've talked before, people who are diabetic, they're smokers, they're in renal failure, they're having cramping in their legs.
Absolutely.
Things are turning colors that shouldn't be turning colors. And things
Absolutely
are turning
right. Yep.
different shades. If you're African American, your top, you should be brown on the top and brown at the bottom. You should be brown on top and black on the bottom. If you're Caucasian, you should be white on top and white on bottom. Not white, then hot pink.
Uh-huh.
That's not a good thing. So basically, and then also we have x-ray in the office. We can do nerve testing and nerve treatments in the office now. And then, of course, we offer walking boots, night splints, ankle braces, and all those things as well. And we accept most insurances. And you can always give the office a call at 937-228-3668. If you are an existing patient, you can schedule yourself online at richfeet.org. If you just want to ask a question, you can text me directly through Google. So if you Google me, there's ability now to text me through Google. So I can get
text.
text.
What, Doc, I think it's safe to say you just have everything there. So,
Yeah.
I mean, and Dr. Gilbertson, wouldn't you say we need to do the Toe and Flow show again?
Yeah.
I mean, even if it has to be by phone, you are fabulous.
Yeah, she
I
taught me today.
Very phenomenal. Very much enjoyed the show. We're getting all kind of messages and responses from the listening audience. We appreciate you for that, and certainly appreciate you being here. Doc, you will be back with us on September the 26th, it looks like. So cannot believe we're moving that fast through the year. So you've talked about a plethora of things this afternoon, but what would be your closing remarks? And we'll allow Dr. of course Gilbertson to give her closing remarks as well.
Basically what Dr. Gilbertson said, look at your feet.
Look at your feet.
Pay attention to them, especially if you have any of these high-risk conditions. If you're diabetic, you're a smoker, you're a renal failure, look at your feet. I tell my patients, your feet are not your childhood feet no more. The things you did as a 5 and 6 year old, you can't do in your 30s and 40s and above. And then once your feet become diabetic feet, they are now high-risk feet. And you have to take care of them, like wash them. Look at them. Look between your toes.
Do you think we really want to ignore our feet? Do people really
Yes,
do that?
they ignore them. They do it every year. People's feet hibernate in the winter months. And then in the summer months, everyone comes in and sees all this weird stuff that's been happening all winter long. And they're like, oh, what is that? Why do my nails look like that? Why my skin looks like this? And I'm like, you ever looked at your feet in 3 months? But they haven't. And then, of course, look between your toes, especially my men. And if you've been in jail, please look between your toes. Because a lot of the men, I haven't seen many women, but a lot of the men who come out of jail come back with this horrific interdigital athlete's foot. I mean, it's dripping on the floor. I culture it. There's like 3, 4, 5 things living between their toes. It's hard to treat. They have to go on antibiotics, antivirals, topicals, and it's really bad. So, and the thing to really say is all of this is preventable. I mean, I would say I'm like the gatekeeper to the feet. I see the feet first.
Absolutely.
I discern what's wrong with the feet. Then I get them to the specialist like Dr. Gilbertson. So I can walk in the room and be like, oh no, give me my phone. I got to call Dr. Gilbertson. I got to text her because she got to see this patient today or tomorrow.
Not next week?
No, today.
We'll
I call her, where are you at? Where you at? I got one. You got to see her today. She needs to be admitted. And I've had probably over my life, since practice, about 10 to 20 of those patients where I walk in the room and the first question I'll ask them is, how long you been smoking? Or what's your blood sugars? Are you on renal failure? But usually the first question always is, how long have you been smoking?
Yes.
And they'll always say, 20 years. I just smoke a couple packs, but I quit last week. I said, no, it doesn't reverse. And that's when I work them up. I tell them to get me my phone so I can call Dr. Gilbertson and find out where she is. And I can get their information, get Dr. Gilbertson's information to the patient so they can go see her today or the next day.
Yeah.
And Dr. Gilbertson, what do you have to say about that?
Toe and flow. I mean, I think the key for saving feet, we're feet fighters. That's like, we're not food fighters.
Feet fighters.
Feet fighters. So I think anybody that has feet, the feet owner's manual says, look at your feet, wash your feet. Remember, even Jesus washed feet. So remember, we have to make sure that every foot, so if you love somebody, maybe they can't reach their feet, maybe their back hurts, wash their feet. I wash my mother's feet when I'm around her. I will take her feet. I will trim her toenails. I will make sure her feet are okay because I care about my mother. So these are small things, but I know as a child, something you can do for someone else is watch your loved one's feet.
Wow. I used to thought it was because I would fly into Louisiana and my grandma and grandpa made me cut their toenails.
Yep.
But now I see I should have been enjoying it more.
It's pure love. It's not enjoyment. It's love. Love makes you wash someone else's feet.
That's a true statement.
That is love. That is love.
Love conquers all, huh?
Yes, it does.
Yes, it does. Dr. Richmond, Dr. Julie Gilbertson, we so appreciate you today. Fabulous guest, fabulous show. Toe and flow, I love it.
Toe and flow. I'm going to make that into a mask and a t-shirt.
Yes, we have to do that again. Dr. Richmond, thank you so very much. You bring such value and information and education to our listening audience. And you know, over the years and even today, through all that the country is going through, our city is going through, we certainly appreciate you and that fabulous boutique that you have.
Thank
so
you.
we want to make sure our listeners get over there and take advantage of all that you have over there.
Thank you.
We appreciate you. We'll see you back September 26th. Have a great day, ladies.
All right. Bye-bye.
You're listening to The Real